Welcome to Muted in Medicine, the podcast where we break the silence on the untold stories and pressing issues within the healthcare profession. Join us as we dive deep into topics that often linger in the shadows of medical corridors and are not discussed in conferences, meetings, social gatherings, and in the hallways. They are often hiding. From navigating errors and facing litigation to the often overlooked realm of mental health among healthcare professionals. Through candid conversations and storytelling, we aim to amplify the voices and shed light on challenges that resonate across the medical landscape. So grab your stethoscope and a cup of coffee and tune in as we uncover the layers of complexity in the world of healthcare that are so muted, yet so profoundly impactful. Hello, everyone, and welcome to another episode of Muted in Medicine podcast. My name is Saba Fatima, and I'll be your host for this podcast. I'm a pediatrician with a passion for helping healthcare professionals facing secondary trauma at work and healthcare, which often they're unprepared to face, and spreading more awareness about it. And with this podcast, we hope to discuss some of the most silenced topics in medicine that are often not openly discussed. Today, we're talking about compassion fatigue in healthcare. As healthcare workers, constant exposure to trauma, long hours, and the emotional weight of patient care can lead to an overwhelming sense of exhaustion. Our lives are so deeply involved in our work that over time it's often difficult to create boundaries between our personal and workspace. And the cumulative prolonged exposure can in turn lead to depersonalization, resentment, empathic distress. It also affects us physically and emotionally, and often makes us feel that we can't be fully present in either space. I know, I feel that way. Brené Brown says, boundaries are a prerequisite to compassion and empathy. But what does that actually mean? Do boundaries mean disconnection? I often get confused about this in my head. And to discuss this with me today and perhaps provide some clarity, I have Dr. Laura Vater. Dr. Vater is a medical oncologist at the Indiana University Simon Comprehensive Cancer Center. She's also a writer, TEDx and commencement speaker, and advocate for the well-being of healthcare workers. She has developed a wellness behavioral tool for patients and clinicians, the SMILE scale. And she co-founded Writing for Wellness, a narrative writing program at the Indiana University School of Medicine. She seeks to enhance the well-being of clinicians by helping reduce the mental health stigma in medicine, understanding and bringing to light shared experiences clinicians face that are often shrouded in shame, and working to improve the culture of medical education and training. Dr. Vater, welcome to the show.
Hi, Dr. Fatima. Thank you so much for having me. I'm thrilled to be here.
We start our podcast by asking everybody a question, and so we'll do the same, and it's sort of a surprise. So what brings you joy in medicine today?
That's a very good question. A number of things. So I'm an oncologist. I'm also a gastrointestinal oncologist. So I'm a subspecialist. And much of the work that I do, people say, oh my gosh, that's so sad. How can you take care of patients with cancer, especially really tough cancers like pancreatic cancer, gastric cancer, colorectal cancer? It's really that connection with patients that brings me joy. And there's actually a lot of laughter in my clinic, and a lot of people are a bit surprised by that patients often tell me about their families. They tell jokes. They are full human beings, and I love being part of their lives and their stories, and that brings me joy. And I love getting to teach. I love having medical students and residents and fellows in my clinic, and hopefully sharing with them some of the tools and tips that I've learned.
Yeah, I mean, that's awesome when you think about oncology. And I remember as a student and resident, I always felt that, yes, it's very sad to be in that field. Especially I do pediatrics, so pediatrics is obviously really sad. But I'm excited to know more about how you can find those moments of laughter. But talking about compassion fatigue, that I'm really interested to learn more about from you. What do you think is compassion fatigue? And is it the same as burnout? Because I got kind of confused when I was reading those terms online, basically.
Yeah, I don't pretend to be an expert on this, right? I haven't spent 40 years researching this, but it's something that I've come to in my writing and what I think about because of what I've experienced in my practice and in my training. I'm sure for you as well, right? I think there is a lot of overlap between what's considered compassion fatigue and what's considered burnout. And sometimes I think we get wrapped up in the definitions of those things. Compassion fatigue is often defined as kind of the emotional, physical, and psychological kind of burden of caring for others, of witnessing illness and trauma and death over time. And sometimes that can lead to just a low level of exhaustion, a lack of motivation to do one's work, and even lead to things like anxiety, depression, other mental health conditions. And so I think that, when we think about burnout, right, there's a lot wrapped up into how we define that term as well.
Yeah.
But I think something that's actually more interesting to me as well that I've explored is really not just experiencing some of that distress related to your work, but also kind of diving into feeling your loss of your own empathy, right? We know that when medical students enter this field, they're highly motivated, they're altruistic, they're smart, they're eager to help others, and they have high levels of empathy. And we actually know that when they go throughout training, their levels of empathy decline.
Yeah.
We also know that after a night of no sleep, so if you've been awake for 24 hours or more, that the areas in your brain, like the activity areas in your brain where empathy is, they have far less activity when you're sleep deprived.
Okay.
We know that doctors who are short on sleep are far less likely to feel empathy and to actually prescribe pain medication. So this isn't just like a fuzzy feeling that gets lost. This actually has real implications for doctors. I don't know if any of that resonates with you or some of your own experiences.
Yeah. I never thought about it that way, but how we feel physically also affects how we're feeling emotionally. So that's very important. I'm curious, you work in oncology, there is a lot of constant trauma of just seeing the losses with your patients, unexpected outcomes. What do you think is the trauma that we usually experience, and how does that affect healthcare workers in general?
Yeah, there's a lot wrapped into that. So anyone who's listening who's a healthcare worker, Dr. Fatima, I'm sure you have all sorts of stories of what you witnessed in pediatrics.
Yeah.
For me as an oncologist, I'm continually facing this kind of challenge of I want to get to know my patients as people. And I often see them every 2 weeks, sometimes every 3 weeks, for as long as they're alive, right? And so oftentimes I'm walking people through challenging decisions, helping them navigate through that, and often through the end of life.
Yeah.
And so I find myself, I've in my training, I'm not sure if this happened to you, but there are definitely times where you'd hear the phrase or you'd read the phrase, well, don't get too connected to your patients.
Mm-hmm.
Don't ask them, don't know too much about their personal stories, because we know that eventually you're going to be walking them through the end of life and it can be more painful.
Yeah.
But at the same time, I really believe that those relationships are protective, right? When I'm looking at my list of who I'm seeing before clinic in the morning, it's not just a person with stage 4 pancreas cancer and then a person with advanced colorectal cancer, right? I'm looking at people that have stories and who I know intimately, who I know very, very well. I know about their families. I know about their hobbies. I know the things that bring them joy. I know the reasons why they're hoping to stay alive for a period of time, whether it's a graduation or a wedding or other big family events. And I keep coming back to this, that if I don't know them as human beings, right? If so, they become dehumanized to me. It dehumanizes me as well. And then I lose that motivation to do my work, right?
Yeah.
And so I have had to find a whole bunch of ways to essentially cope, to know that connection, that loss is going to be painful over time.
Mm-hmm.
But at the same time, I'd rather build coping strategies into my life rather than disconnect. So I have this whole process. If a patient passes away, right, this driving in the car in silence and honoring them, a HIPAA protected journal where I'm not including their information, right? And usually I'll go for a walk when I can and honor them in some way. And I also have, even when my patients are alive, and right. So yesterday I was in clinic, and yesterday was just a particularly hard day.
Yeah.
And sharing a lot of bad news. patients whose disease was either worse than we thought or they'd progressed, meaning their cancer got worse. And that takes an emotional toll on you. And when I got home, I just kind of felt that a level of emotional exhaustion, right? Sometimes it gets to the point where you say to yourself, how is this sustainable? Right?
Yes.
How can I keep doing this? And so I think it's really important, and perhaps we'll talk more about this throughout the course of our podcast here, but it's really important that when you do this work, you recognize that your work is not normal. What we do every day is not sitting in an office and just going to meetings and talking about engineering or business or accounting, right? We are in people's lives. We are part of their lives, and we are witnessing really hard things that sometimes they don't even share with their own loved ones, right? Really difficult thoughts and feelings that they experience. And that's going to take a toll on us. So I think to pretend that we are superhuman, that we are robots, that this isn't going to affect us, I think it's a disservice to our field. We're better off going and knowing, okay, this is going to be really hard. It's also going to be really meaningful. And there's going to be elements of joy and fun and laughter, but you're going to be sharing life with another person and helping them through something hard, and that's going to affect you. So here are a whole bunch of things that we can do, both individual strategies and, institutional or systemic level strategies that can help.
Yeah, that's so true. I do think the trauma builds over time, though, because I wonder, I read your post on social media and I read it and you talk about your hard days, and I really appreciate that you're acknowledging that. But it kind of builds over time. And how do you preserve yourself in that process? Because I feel like recently I've started disconnecting myself again because I felt like it was too much and it was taking a toll on me. And even though I totally understand you that we got to humanize the patient, we got to hear their stories, but how do you preserve yourself? Because it's hard.
I think that you have to do what you need to do in order to survive and in order to do your job well, right? You can very well do your job as a pediatrician, even if you don't know those nuanced factors about your patient who's 5 years old. And there may be seasons of life where you may be able to have more capacity to know them and care for them in that way. But it's also, I think we need to normalize that we may not always have that capacity, right? We either may not have the time to do that or the emotional energy to do that. And we shouldn't shame that, right? I think that it's a very individual decision, and it can change. Sometimes you just do not have the time to go into all of those things. If, you're covering for your colleague who's out of town or covering for someone else, or your clinic is just busier than normal and you're just trying to get through your day. So I think that part of what you're experiencing, right? I think that then there can be shame wrapped in that of like, oh, am I not a good doctor because I don't know how this child enjoys spending their time. Right. I think that you are a good doctor. And I would say this to anyone who feels the way you feel, is that you are a good doctor. And sometimes you have to do what you need to do to remain competent in your role. And sometimes if it just feels like it's too much, then I think it's okay to pull back and then to come back to those feelings and emotions when you have a bit more space and time to process those and cope. But there are going to be times when over time, it can get harder. I'm experiencing what you're saying. It gets harder over time, right? It can kind of build up. It's interesting. And I would love to talk to you about this idea too of, do you develop emotional calluses, right? That's something that I think about a lot, right? Because, and we can talk more about that. I don't mean to just derail your podcast, but I think, what is an emotional callus and what does that look like? And is that okay? And secondly, over time, the trauma can build because more people that and for me, what I'm finding, right, I'm in my attending career, and the more that I know someone, let's say I know them now for not just months, but now years, that cancer recurrence for that person that I walked through chemotherapy and surgery and surveillance over time, and when that scan comes back saying that they have cancer again, it just feels so devastating. Couple nights ago, I was just laying in bed awake because I knew about the results of a scan of a patient I was going to see the next day. And I was just thinking about, how is this person, right? I'm holding this information that's going to change their life completely, right? And I kept thinking about them that night and how they were doing, and right, if they had read their scans yet, and right. And so there's no way that we can do this work and not be affected if we're human beings, right? And it does get harder over time, either because you know a person or their family to a greater degree, or because some of those experiences build up.
Yeah. And I mean, what you said about emotional callous, I think I am a different person than I was 8 years ago, because I trained for 3 years. I've been an attending for 5 years. But yeah, I do think I'm a different person because I've accumulated so much trauma over time that I didn't know that I signed up for. So yeah, it does accumulate over time. Do you, when you go in a room, do you set some boundary though? Or would you recommend for you not to insert yourself into that patient situation, and how to prevent that compassion fatigue, And I read something where you said that you did not cause the disease, like that sort of thing. Yeah.
Yeah, I think if you're a caring person, and especially if you can in some way, right, this person, you connect with them in some way, it's going to be harder. But when you go into a room with a patient, it's okay to set a boundary, right? It's okay to do that. And I think that it's different for everyone what those boundaries look like. Yeah. Most of the boundaries that I set when I first started my attending career, I used to give out my email. I didn't ever give out my personal cell phone. I have some of my colleagues that do that. And I always kind of felt guilty for not doing that, actually, because some of my colleagues would do that. And I thought, oh, am I a bad doctor because I'm not giving out my personal cell phone? But I did give out my personal email, my personal work email. And I won't go into details, but I was bombarded with messages. Not most patients respect it, but you can be bombarded with messages in a way that's not a HIPAA compliant form, a HIPAA compliant avenue. Mm-hmm. And then you can have patients become upset with you for not responding within 12 hours to something like that, right? Mm-hmm. And so that's a boundary that I have set up where I have a layer of protection between my patient's first contact is with our nurse who triage concerns, because I have so many patients who are on chemotherapy, and I have a panel of about 400 patients, right? And so I have a lot of patients on active treatment and who have really awful cancers, and I care deeply for them, but I also need a layer of support that's HIPAA compliant. So it's a work phone, and it's a messaging system, and it's an after hour system. And so that's a clear boundary that I set up just to try to help protect my time with my family, and also my patients. And then there's also that, how much do you share about yourself? Yeah. Right. I think that's part of it. I often ask my patients, because it's part of the social history that I collect. All my patients are adults. Many of them, not like you, not like your patients are, little. My patients are often 50, 60, 70, or 80, but I have some very, very young patients as well, in their 20s and 30s and 40s. But most of my patients are adults, and they, will share about their grandkids. They'll share about their families. They'll share about their hobbies, right? So I like to know those things about them. Sometimes I will share, oh, I have a daughter that's about the age of, your daughter or whatnot. But I often try to make it about them, right? Yeah. If they, well, I'd love to hear, what boundaries do you have in your clinical work?
I think I started doing that thing where I started disconnecting a little bit from the personal side of it. And I know that's not the most accurate thing to do. And, there's shame around that, like you said, but I did notice that it was spilling a lot over in my personal life, just knowing the patient. And when you know the patient and you lose that patient, it's so much more harder, like you said. And I do pediatrics, but I'm a hospitalist, so we take care of a lot of oncology patients. So, as a pediatric hospitalist, so that one is the harder. So I started disconnecting a little bit. And then I went back when I had more capacity to, start asking those questions. But I think I agree, it's always harder for me when you know the patient more when you lose them as well. And also in pediatrics, it's sometimes unexpected too. So that's even harder, if there was a natural trajectory of things and you felt like you had that closure, I think not getting that closure has been harder for me. So,
I'm sure people say this to you all the time, but being in pediatrics, being a pediatric hospitalist where you're witnessing kids that have either serious infections, cancer, other major medical problems, and sometimes even trauma at the hands of their parents or caregivers.
Yes.
Right.
Yes.
And so there's so much in pediatrics that is just emotionally painful.
Right.
And I think that at least my perspective is that we have to release the shame, right?
Yeah.
If we are competent in our role and we're caring for that adult or that child with, with evidence-based medicine and with detailed care, right? We need to be able to release that shame that we may feel from not being able to either have the time, energy, or emotional capacity to be as emotionally available as we would like to be in an ideal fashion, because we are just human beings, right? And having a chronic stress response, we know, is very bad for our health. Yeah. And, it's even been linked to conditions like cancer, sleep loss, sleep deprivation, especially when you have that worry, and the inability to fall asleep has been linked to a number of chronic conditions. Yeah. So we owe it to our patients, not just our current patients, but our future patients. I think a lot about our longevity in this career, right? Yeah. How do we protect our longevity to do this work? Yeah. A lot of it is external factors. How fast do we have to move? How many patients do we have to see? What are the insurance requirements, peer-to-peers, documentation requirements, inbox management, lack of ability to take vacation and not be checking messages or emails on vacation, right? So there's a lot of institutional or even systemic level factors, but there's also a lot of, secondary trauma of our work. So we have high stress environments, and for many people, the stress, the anxiety, or whatever you call exhaustion can get to a degree where they just need to leave the field of medicine altogether, or worse. Yes. They decide to end their life. Right. And so there are real repercussions to clinicians. And so I think it's essential that we think about releasing shame to protect our health. And I think that if the stress response if you're feeling you're at a point where your stress is your level of chronic stress is so high, it's okay to emotionally detach if you need to. Right? Not allowing those things to kind of bubble up and kind of burst over, but really a layer of a small amount of detachment so that you can continue to do your work, and then having regular, spaces to process and cope. For me, that's regular therapy. That's writing. So I do a lot of journaling, a lot of narrative writing. I do fiction writing. It is sometimes, like yesterday when I was driving home, I just called my husband. I was like, I need to think about something that's not related to cancer just for like 10 minutes. Can you just and so he was telling me about my daughter's day and, things that had happened. Yeah. To the grocery store and, what we were going to do this weekend, maybe go to an apple orchard, right? So sometimes it's okay to either distract yourself, to emotionally detach and right. I haven't fully formed my thoughts on these emotional calluses, right? Something that I'm thinking about a lot and writing about. But, calluses are essentially, let's say you've got, I grew up on a farm and we had horses, right? So I did a lot of like shoveling, carrying buckets, and I was also a gymnast. And so anytime you'd be like working on the bars or you'd be like shoveling, of course, I had these huge calluses as a kid, right? Mostly because of gymnastics, but other factors, right? And they provide you with a layer of protection from a repetitive stress, right? A layer of protection from a repetitive stressor. And it's your body's way of protecting you. So if you're, going through your job and you realize that after a couple of years of doing what you do, that you're in a situation that maybe 5 years ago, you would have just been emotionally just like torn apart. You would have been maybe crying in the room along with the patient. You may have walked out of the room and need to go to the bathroom because you were tearful. And it's okay to express emotions in those moments. But sometimes you will be sitting in these emotional moments and you will care. You will feel bad for the person. You will wish so badly that this was not happening to them. But there's almost like a layer of am I using the word right? Maybe there's a different word here, but like almost like an emotional callus that in a way, from a repetitive stressor of something, maybe it's that the work you do, it's normalized some of this normalization. And so your response is not as emotional. There's probably a lot of physiologic things happening. Right? About that, but I think it's okay. Yeah. You shouldn't. Sometimes I used to carry deep shame. Like if I was in those moments and I was like, why am I not as like emotionally distraught, right?
Yeah.
And just knowing that maybe that's part of, in your profession of gaining experiences, that you have seen so much and that you're there present, but you may not experience the same level of emotional reactivity or emotional response. And that's okay.
Yeah. Let me ask you this. So when your patients who have bad outcomes or they lose themselves to the disease, I think being a physician, does that also put into the equation that I couldn't do something to prevent this from happening? Does that also happen in terms of the shame and guilt that you're feeling? Because there's one thing that you're feeling bad for the disease and the person, and I feel like that's a little bit easier to disconnect from, but the responsibility of not being able to prevent it, does that happen to you?
I think it happens to anyone that practices medicine. I just wrote an essay about this called The Holiday Card, and it was like my processing the unexpected death of a patient, which I've shared with the family's permission, and it's still de-identified. But when a person dies unexpectedly, it is a normal and natural response for your first thought as a physician to say, what could I have done differently, right? What happened? What could have gone differently? And so most physicians, when this happens, they immediately go back to the chart. Like before they do anything else, before they tell another soul that this has happened, their first instinct is they're like sifting through the patient's chart with like a fine-tooth comb. They're saying, what was the dose? What were all the doses of the medicines? How often were they given? For me, was the chemotherapy given per protocol? Were there other red flags that we should have seen or changed? And then it may lead to, you're talking to a family, you're exploring symptoms that might not have been there, especially if the person passes away at home, right? It may happen in the hospital or at home. And then it is sometimes followed by an autopsy. But even after all of these things, sometimes we just do not know. And I think that uncertainty and that what feels like randomness is just devastating, right? So that uncertainty and the randomness is devastating. And like we acknowledge this rationally as physicians, we say, okay, well, we signed up for this. We know that these are terrible diseases. We know that oftentimes the medicines we use have side effects that sometimes we cannot predict or prevent no matter what we do. But that doesn't change the fact that it takes a huge emotional toll. And in this essay and in this experience, this family had given me a holiday card, and I had put it in the side pocket of my work bag. And I had, of course, opened it and looked at it and was like, oh, that's nice. And then this patient passed away unexpectedly. And I could not remove this holiday card from the side pocket of my work bag. It traveled back and forth with me for more than a year, back and forth to work, because my therapist calls it a transitional object. I kept it there because perhaps I needed to. It was my way. I didn't look at it, right? I just was aware of its presence. I knew that it was with me. And perhaps, if I kept it in that space, maybe it meant that her death wasn't real. And it took a lot of kind of emotional processing and therapy for me to realize why is my mind doing this? Like, and it was kind of this whole process of going back through everything, and there were no answers on why this happened. And it is so unsettling as a loved one and as a physician, as a nurse, as a physician, as anyone who's in healthcare, to know that unexpected outcomes happen. And to try to find a way to just be okay with that is really, really hard. And then if you add the layer, so not in this case, but if you add a layer for any physician, if there's an element where that physician thinks, oh gosh, I did something wrong, or I could have done something differently, that adds another layer of shame and trauma, right?
Yes. Yeah. I mean, you couldn't have said it better. I mean, the uncertainty is so unsettling. And when you were saying it, I have experienced it. So it's like you were speaking my mind. So thank you for saying that. Switching just gears a little bit. What do you think are the problems in our system? And, that kind of compassion fatigue, which feels like the EMR, and you talked about the sleep deprivation, and what are some of those factors that contribute to it? The moral injury too, like with the prior auth and all those stuff.
Yeah, I think a lot of physicians that I know, thankfully this hasn't been for me, typically this isn't for me, but I know a lot of physicians face moral injury because there are so many people that need their care and they don't have enough time. So either they're faced with really short clinic visits, 10, 15, 20 minutes, where they have to accomplish a whole bunch of things in a short period of time to provide this person with adequate care. Or they're triple booked, right? They're double, they're triple booked. Yeah. So then they're facing this exhaustion and this external pressure for productivity. And they're saying, I cannot provide good care. And it's ethically causing moral injury. So I think that's one thing that causes moral injury to a lot of physicians is this pressure for productivity, especially for employed physicians that have less control over that, feeling like they wish they could provide care at a higher level, more detailed care, more comprehensive or empathic care, but yet they can't because of the structure of their work environment or just that there's so many people that need care that need to get in to see a doctor. So I think that's one thing that causes moral injury. I think something else that can be a pain point for many doctors is that they spend a lot of their time not with the patient, right? Yeah. So we know that for every hour you spend with a patient, usually it's like 2 hours in a chart. So it's not just first time you meet a patient, you're sifting sometimes for me through 200 or even 1,000 pages of records. You are coordinating care with other specialists, you're writing orders, you're getting insurance approvals, insurance is denying things. So then you have to try to get on the phone with the insurance company doctor, and that takes forever and sometimes doesn't even happen, right? Yeah. You're on hold sometimes for hours. That can be just mind-numbingly frustrating. Yeah. And I think that a lot of physicians feel like they may not be working to the level of their capacity because they don't have the administrative support that they need. Someone to help them triage an inbox, answer messages, do refills, help a person to know if their labs are, normal or to walk through that. And so I think there are a lot of challenges that doctors today face. And then there's just also, I'm sure you've witnessed this, we have patients that are either underinsured or uninsured. And so we know the care that they need. And it is just absolutely heart-wrenching when you have a person diagnosed with cancer and they cannot get the treatment they need because they don't have insurance. And I think that causes a huge amount of moral injury to physicians.
Yeah. Yeah, I mean, I can't even imagine, but yeah, we struggle with that all the time. Just what is the social, like, how do we get this patient treatment, or how do we get this in pediatrics also, how do we get this patient to a safe home, and what if we send them home and it's not safe? So yeah, it is quite tough. Do you talk about the sleep deprivation thing and the problems with our training that contribute to some of this? Would you like to elaborate on some of that? Because I know you're a fierce advocate for trainees, so.
Thank you. And thank you for the work you're doing too. For those of you joining who may not know, the culture of medical training for more than 120 years really has been this model where you work very, very, very long hours and you experience sleep deprivation as part of your job. You have very little time off. You don't get paid very much at all, usually less than minimum wage for the hours that you work. And usually you don't have much usually no negotiating power. And you have concern that if you were to try to advocate for better, that you would face professional repercussions, right? Yeah. And so many doctors, now things have improved since some of the work hour restrictions that have come through in the last few decades, but many physicians still regularly are awake in their training for 24, 28 hours, even 50 hours, 72 hours for the whole weekend. They're working more than 100 hours a week. And what happens is they're just told not to report those hours. So on paper, they're working 80 hours, but in reality, they're working much more, whether that's direct clinical work, inbox management, doing modules, doing other things related to their work. Right? But the sleep piece, the sleep deprivation piece, doctors do still work very long hours. But the problem is that we have a lot more data about sleep than we had 30 years ago, thanks to researchers like Matthew Walker and colleagues and people across the world who really have discovered that sleep deprivation is a very poor tool for learning. when you are awake for more than 16 hours, your brain's kind of like a strainer, right? It's just like information goes in and just like pours out. Your ability to process information, your ability to make decisions, even your physical coordination, if you're doing a procedure or you're driving, right? We know that both needle sticks and car accidents go way up in doctors who are sleep deprived. It's a patient safety issue, and it's also a health issue, right? Doctors who are sleep deprived, it's an independent risk factor for anxiety, depression, and suicide, meaning if you have none of those conditions beforehand and then you're sleep deprived, you are at risk for anxiety, depression, and suicide, right? That is a huge factor, not to mention your risk of cancer more than doubles from chronic sleep deprivation, your chance of diabetes, weight gain, cardiovascular disease, even Alzheimer's, right? And so if we really care about our physician workforce, and we care about not just, them in this moment, but who are they going to be for the next 30, 40, 50 years, their ability to practice medicine, their ability to have a meaningful career and be able to stay and do this work, we really have to focus on their health. And a huge part of their health is sleep. It's not just for the safety of patients, but it's truly for the safety and the health of doctors, that I really think we have to do away with this unhealthy belief that we're robots, that we're somehow superhuman, that we just don't need sleep. I think there's more and more conversation about this. And it's my belief that sleep deprivation is a poor tool for training and a poor tool for patient care.
And I don't know, perhaps it might be glorified in our culture. Like they glorify it like it's a good thing. And, if you're tough enough. But yeah, I couldn't agree more. What are some of this? So, you talked about it briefly. You talked about your writing. I do want to hear more about what you do to cope and still keep showing up every day. Like, what are some of the strategies you do to fight this and be a compassionate provider every day?
Well, I have experienced both sleep deprivation related to suicidal ideation in my training. I have also experienced fatigue of my empathy, whether we call it compassion fatigue or loss of empathy. I've experienced that, particularly related to sleep deprivation. And I have made a number of very conscious, strategic choices to try to protect my health. Now, this doesn't mean that it's always working, but for me, thankfully, oncology has few emergencies. So when I'm on call, I'm part of a big academic practice. And so I'm only on call for about 4 weeks of the whole year. I only work like 3 to 4 weekends the whole year. I have 3 full clinic days a week, but I get to work from home 2 days a week and do writing and academic work and other initiatives that I'm part of for patients with young onset cancer, and part of a leadership group that we're in. And I do get to do stuff like this. And so that helps to protect my health, because I know that for me, when I'm sleep deprived, I know that affects my health and my ability to practice medicine. So, and then having three full days of clinic, after a full day of clinic, a busy day of clinic, I truly feel emotionally wiped out. And it's really funny because in my residency, I did work long. I'd sometimes work, 28-hour shifts or longer, but I would just, as a resident, you work 6 days a week, 1 day off. I look back and I say, how in the world did I do that? Maybe there's a level of responsibility that comes with being an attending. That's, I think, a higher, there's a higher burden there. It's also those relationships over time that can sometimes lead to more relational development, but also can lead to more emotional exhaustion. And I'm also older, right? So probably all those factors combined. But after a long day in clinic, oh my gosh, I'm like useless. I'm like, the drive home, I'm like, I cannot do anything. I'm like, here I am. So I can imagine doing that 5 or 6 days a week. So that's one strategy, is I try to be really intentional about how I spend my time. Of course, I try to have regular sleep habits where I get at least 8 hours of sleep a night, as much as I can. I'm grateful that my daughter sleeps through the night. She's 8 years old. So I try to exercise regularly as best I can. I go to therapy. I have a writing practice. Sometimes I just drive home in silence and I just try to process the day. And then I also have, there's a lot of data behind both meditation and gratitude practices. I have both of those things as part of, tools that help. And then sometimes I just need to, either take a hot bath or go for a walk. I love being outdoors. Sometimes it's like watching a movie that has nothing to do with medicine that I've seen 100 times that I don't have to think through, right?
Yeah.
And I think that there's a whole bunch of strategies and they're different for everyone. But
Yeah.
I think for me, trying to be really strategic of how I set up my career so that it allows for, I almost think of it like when I'm in clinic, sometimes it feels like I'm sprinting.
Mhm.
And then the next day I get to kind of recover. It's like my recovery day. And then I have 2 days where I'm kind of like sprinting, and then I have recovery days. And I know that's really hard as a hospitalist, right? Because you like sprint for like 7 days and then you're like off for 7. So it's like your period on is more like a mini marathon and then you're off, right? I don't know. What about you? What have you found has been helpful for you?
I mean, yeah, I think because I am a hospitalist, so we do have like shift work. So yeah, we work for 3 or 4 days and then we have that recovery time. And so yeah, I do the same, like do something that's not related to medicine. But I do feel like it might be tough for like some people who are supposed to work 5 days a week, like, and there's also this question about how do you create that life for yourself where you can cut your clinical time. And, I think that's a whole different discussion and maybe not possible for everyone. But I do know that when I come home from a work day, I don't feel like I'm present, for my home. And that has some shame to it too, right? Like I feel a lot of shame around it. So I'm curious, do you feel like when you're coming home from work, like you can switch gears and be present, or is that just a myth? Like, you can be fully present 100% in both spaces.
Yeah, I'd like to believe and try to tell myself that I can be fully present in both of those spaces. But I don't think that that's realistic for most of us. And I think that it really depends on the day. There are days that for whatever reason, my day's lighter. I don't have as many patients or, there are days though that I have back to back to back to back to back patients. Sometimes, especially if they're not doing well and, working clinically, you're constantly making decisions, right? You are constantly, it's physical exhaustion, it's emotional exhaustion, right? And sometimes you don't even have time to care for your own basic needs, like going to the bathroom. I don't eat lunch during clinic and I try to drink water, but sometimes you will have a day, and I had 2 days like this past week. Part of this is because I'm covering a colleague who's out, but I just had 2 clinic days where I drove home and I was like, I'm spent. I have nothing left in the tank. There is nothing left. And I got home, sometimes I can get home by 5:30. I didn't get home till 7:30, 2 days this week. When I got home, I was like, hi, I'm just going to sit here and I'm going to watch a show that has nothing to do with medicine, and I'm going to eat food. And that's all that that's all that I have the capacity for. Right.
Yeah.
And I think that there is a lot of shame, especially if you are married, you have a significant other, you have children, you have parents that you might be caring for. There is a lot of shame surrounding, and I should just be able to be superhuman. I should have an unlimited amount of emotional and physical energy. But I think that that's just impossible. Just a reminder that the work we do is not normal. It is going to take a toll on us. It's meaningful work. It's important work, but we are not going to just be able to like flip a switch and be like, everything's great. I am, fully charged. My battery was fully charged. And I think about that a lot of like, you will be like, it's almost like your phone, like you plug in your phone at every night, right? To recharge, right? I feel like clinic or especially a hard day as a hospitalist, pediatric hospitalist, right? Your battery can be drained. Like, so it's like flashing low battery. Like I'm flashing low battery, like my phone, maybe it's just going to like power off on its own because we do not have unlimited capacity, that we're human beings, and we require that pause for restoration. And to think that we're just going to be able to be these robotic, perfect creatures in all aspects of our life. And especially, kids, just like my daughter, she'll come home and she'll be like, Mommy. And then she's like, and she's like, will you? I love, my husband is great. He does a lot of the stuff at home, but I still love to cook. And so my daughter's like, can you make me this? Can you make me this? Can you make me this? And I'm like, okay, honey.
Yeah, that's the same experience that I've had. And I feel like because I was doing hospitalist work, 99% of the time, my shifts were when I come back home, I was emotionally tapped out. And so I took that decision conscious decision to decrease the number of shifts I did, but it worked financially for our family, but I do realize it might not work for everyone, so that's also because I just felt like when I went home, I have a 4-year-old and I did not have any energy preserved to give back. And so, yeah, I always think about, when it doesn't work financially for someone, what do they, yeah. So
yeah, I think that's a real thing. There are people that either they have a big mortgage, or they have whatever their financial stressors are, right?
Yeah.
And or they're thankfully, my cost of living is, where I live, the cost of living is lower than the national average. And we have chosen to live way below our means, right? Yeah. Just because you can buy a big fancy house, like, don't do it, because it may trap you in a clinical job or a type of productivity model that is just not sustainable emotionally or physically, right? So I think that, and I also think there's shame in, especially both men and women who choose, right? Sometimes I feel guilty that most doctors work 4.5 clinic days a week. And sometimes I feel shame that I only have 3 clinic days a week, but I do a lot of teaching and I do a lot of academic work along with that, right? So I'm full time, but I'm also have that ability of working from home. And often on my work from home days, I have tumor board meetings. I'm catching up on clinical notes and documentation. I'm getting pages like today. I have pages from the ER and pages from my nurses. And so it's not as if it's a non-clinical day, but I think there is some guilt associated with, am I working to my capacity to serve in my role? And I specifically know women who were told in their training that they would be a waste of a role, or a waste of a medical school slot if they decided to work anything less than full-time. And full-time in medicine is like 80 hours a week, 60 to 80 hours a week. So even if you work like 40 hours a week, that's people consider that like part-time, even though that's like a regular job for other people. Because our days are often very long. Like my clinical days, usually I start my tumor board meeting at 7 a.m. and I'm like, finishing up clinical work 5:30. So I would just say release that shame. Think about your long-term career. It's going to be better if you can find something that's sustainable for you so that you can continue to do this work. And if you decide that this clinical work is not for you, release that shame, because there's a lot of other really good things that you can do too.
Yeah. And I think that I posed you that question before we did the podcast that, is it okay to quit? Because I just recently had a conversation with a colleague, and I could see like she felt a lot of shame around that topic of not being able to do it. Because and I felt it too, even when I went a little bit part-time, I was like, well, why can't I do it? So what do you think? Is it okay to quit?
Yeah. I have a lot of people that reach out to me on social media and they feel like failures. I had one person that say, hey, this job is not the right fit for me. And I'm a failure. I'm a disappointment. Why can't I cut it? What's wrong with me? Right. And it's so, it's like, that's how people end up developing depression and suicide. That's one of the factors. Right. And so I would say, first of all, quit your job. Don't ever quit your life. Right. There are bad jobs in medicine. There are jobs that just aren't the right fit. And if you kind of walk through this and there's not a clinical job that is a good fit for you, there are a ton of things outside of clinical medicine that you could serve society. And not that you need to do that, but you could work in public health. You could work in schools. You could you could help other clinicians experiencing, exhaustion. There's all sorts of things that you could do. And maybe you just needed some time where you're just going to like go sit on a beach for like 6 months of your life. I think, there should be no shame in that. You are a good person, and it's not that you're defective because it wasn't the right fit for you. And I just hope that people know that they have more options than they realize and more negotiating power than they may realize.
Yeah. How do you think, I ask everybody this question about institutions, because I do feel like we put a lot of pressure on us as individuals and how we can make things better. But do you know how institutions can help prevent some of these problems, or do you know of any good models? I'd be curious to know.
Yeah, there used to be this thought, I think, it's called like Wellbeing 1.0, where it was like everything related to physician burnout should be a individual solution. And you just need to exercise, and you just need to sleep, and you just need to meditate, and you just need to do some yoga, and just like, you fix yourself. Okay, that's the problem. You're the problem. Fix yourself. And now there's increasing recognition that it's really right? If it's like the doctor at the center, it's like, I think of it like all of these things around that are like pushing and causing external, right? And we talked about a lot of those things like productivity pressure and insurance pressure and peers and documentation and inbox management. And people who are like on their epic inboxes, like in the grocery store line, like, I just got to get through, there's so many external things, not being able to take vacation because they don't have someone to cover them. Perhaps it's like, they don't have clinical support from either a registered nurse or someone else that can help them with things like, I have a patient that needs a scooter. This person needs FMLA paperwork. Right? All these things that they end up needing to do. And so, yes, I think the biggest thing is that people need adequate support. A lot of that is like inbox and admin support. They need adequate support. That goes a huge way, right? A huge way in reducing exhaustion and burnout. But they also need reasonable work hours, right? They should not be pressured to work, 60, 80 hour or more hours a week just because that's what they knew in training, and that became normalized and expected of them. And they should be allowed, to have a reasonable period of rest and be able to take time off, right? And I think that institutions could do a better job. And I'm part of a lot of, now that I'm kind of on the other side of things, I'm part of a lot of, committees and institutional efforts to try to improve those things. But it can be very hard as a group of physicians when you have limited power to control a lot of those external factors.
Right. Yeah. You're part of the system, right? Tell me more about the SMILE scale. I'm curious to know.
Yeah, it's readily available on my website if anyone's interested, but it's a tool. It's a wellness behavioral tool that I really created for myself when I was an intern, because I needed a way to make sure that I was prioritizing my own health in a way that like I didn't have to think about. Right? So I created, it's each letter of the word SMILE stands for one healthy habit that ideally every person should be able to perform each day to be healthy. So S is sleep. Did I get at least 7 to 9 hours of sleep at night? Move my body. Did I exercise ideally for at least 30 minutes or more? I is about stress reduction. So inhale and exhale. Did I reduce my stress in a healthy way today for at least 10 minutes, whether that's prayer, meditation, walking in nature, music, reading, something like that. L is love and connection. Did I meaningfully connect with one of my closest relationships today? Really, there's 1 to 3 relationships that we know are the most protective, and that meaningful connection is protective for our health over time. And then E is eat to nourish. Have I eaten at least 5 servings of fruits and vegetables a day? So it's kind of like a 5-point scale. Sometimes when I was like a medical student or a resident, my score would be like a 0 or a 1, and I'd feel a lot worse. But then, so it was just like a gentle nudge. And a lot of times, some of that was outside of my control. But then I would look at what are the factors that are truly in my control, and then can I release some of that pressure when some of that's outside my control?
Yeah, I almost feel like we should put it on our fridge, and how I give my daughter sticker charts. I could do that. That should totally work.
I love that.
Yeah, I think I'm going to do that. I think we're moving towards the end. It was such a pleasure to talk to you. I do know, I just want to know, do you have any parting words for whoever who is listening, who may be suffering from some sort of compassion fatigue or burnout or depression, anxiety, any of the sort related to healthcare?
I would just say, be kind to yourself. This is not something that you've done wrong. It's not that you are somehow inadequate or that you lack resilience. This is really an occupational hazard of doing this work in a repetitive fashion, and that you are a good clinician, you are a good person, and that you deserve the health that you strive so hard to give to other people. Yeah. So be kind to yourself. Really look at the structure of your life, and are there things that you could realistically change to be able to better protect your health? And then try to release that shame that's associated with so many of those things that we talked about today.
Yeah, awesome. Thank you. I have a tradition at the end, and I know you like poetry and writing too, but I read a poem at the end. So if you'll stay with me for that, and then we'll end.
Wonderful.
It's called Kindness by Naomi Shihab Nye. Before you know what kindness really is, you must lose things. Feel the future dissolve in a moment, like salt in a weakened broth. What you held in your hand, what you counted and carefully saved. All this must go, so you know. how desolate the landscape can be between the regions of kindness. How you ride and ride, thinking the bus will never stop. The passengers eating maize and chicken will stare out the window forever. Before you learn the tender gravity of kindness, you must travel where the Indian in a white poncho lies dead by the side of the road. You must see how this could be you, how he too was someone who journeyed through the night with plans and the simple breath that kept him alive. Before you know kindness as the deepest thing inside, you must know sorrow as the other deepest thing. You must wake up with sorrow. You must speak to it till your voice catches the thread of all sorrows, and you see the size of the cloth. Then it is only kindness that makes sense anymore. Only kindness that ties your shoes and sends you out in the day to gaze at bread. Only kindness that raises its head from the crowd of the world to say, "It is I you have been looking for," and then goes with you everywhere, like a shadow or a friend. Thank you so much for doing this with me today.
Thank you so much for having me. It's been great.